real-life clinical scenarios for practical application of knowledge, group discussions of complex cases enhancing collaborative learning, facilitated online discussion boards fostering interactive engagement. 2 mock exams with detailed answers were used for self-assessment. Personalized feedback and one-on-one assessments are available upon request. Optional one-to-one guidance with extra support. The Greater Than 40 Hours course encompasses lectures, over 2,000 MCQs, and an additional 10 hours for webinars, tutorials, online engagement, and interactions. Join us in emphasizing the development of effective clinical reasoning strategies rooted in the best evidence and critical reflection on practice. Take control of your exam preparation journey. For more details and to register, visit us at worldkidneyacademy.org. We look forward to supporting your journey in nephrology. Join us today and take the next step in your nephrology education. Flagship on Welcome to the Nephrology Exam Preparation Program. This flagship online initiative is designed to set you up for success in your nephrology career. Our program is organized into 10 comprehensive chapters, covering the entire nephrology curriculum. Whether you're aiming to build core knowledge or advance your expertise, we've got you covered. Our lectures are designed to deliver essential knowledge and prepare you for your exams. Each topic includes 5 diverse questions to reinforce your learning, followed by concise discussions on clinical presentations, management, and updated guidelines. We've structured each topic to fit within a 10 to 15-minute time frame, with the full lecture, questions, and discussions wrapping up in 45 to 60 minutes. This approach ensures both efficiency and depth in your learning experience. Over the next 10 weeks, enjoy a dynamic learning experience through our interactive platform. Dive into comprehensive keynote lectures, engage in diverse discussion boards, and participate in specialized journal clubs, all tailored to cover the core elements of nephrology. Key features: asynchronous audio-video lectures covering essential exam areas, comprehensive multiple-choice questions, MCQs, with answers and explanations meticulously aligned with the latest guidelines, designed to cater to various nephrology exams on a global scale. Access an extensive question bank of over 2,000, making it the largest repository of practice questions available on a single platform. We recorded synchronous tutorials and online webinars addressing specific concerns. Reflective practice on international guidelines, guiding you on exam approaches. Real-life clinical scenarios for practical application of knowledge. Group discussions of complex cases enhancing collaborative learning. Facilitated online discussion boards fostering interactive engagement. 2 mock exams with detailed answers were used for self-assessment. Personalized feedback and one-on-one assessments are available upon request. Optional one-to-one guidance with extra support. The Greater Than 40 Hours course encompasses lectures, over 2,000 MCQs, and an additional 10 hours for webinars, tutorials, online engagement, and interactions. Join us in emphasizing the development of effective clinical reasoning strategies rooted in the best evidence and critical reflection on practice. Take control of your exam preparation journey. For more details and to register, visit us at worldkidneyacademy.org. We look forward to supporting your journey in nephrology. Join us today and take the next step in your nephrology education.
Hello, everyone. Thank you very much for joining us today in your most likely a
Uh,
weekly.
can we wait for another 5 minutes? A lot of people,
Yeah, I'm admitting some.
yeah.
Yeah,
Right. So let's
just wait. Okay, I will wait for a few minutes then.
Welcome to the Nephrology Exam Preparation Program. This flagship online initiative is designed to set you up for success in your nephrology career. Our program is organized into 10 comprehensive chapters covering the entire nephrology curriculum. Whether you're aiming to build core knowledge or advance your expertise, we've got you covered. Our lectures are designed to deliver essential knowledge and prepare you for your exams. Each topic includes 5 diverse questions to reinforce your learning, followed by concise discussions on clinical presentations, management, and updated guidelines. We've structured each topic to fit within a 10 to 15-minute time frame, with the full lecture, questions, and discussions wrapping up in 45 to 60 minutes. This approach ensures both efficiency and depth in your learning experience. Over the next 10 weeks, enjoy a dynamic learning experience through our interactive platform. Dive into comprehensive keynote lectures, engage in diverse discussion boards, and participate in specialized journal clubs, all tailored to cover the core elements of nephrology. Key features: asynchronous audio-video lectures covering essential exam areas, comprehensive multiple-choice questions, MCQs, with answers and explanations meticulously aligned with the latest guidelines, designed to cater to various nephrology exams on a global scale. Access an extensive question bank of over 2,000, making it the largest repository of practice questions available on a single platform. We recorded synchronous tutorials and online webinars addressing specific concerns. Reflective practice on international guidelines, guiding you on exam approaches. Real-life clinical scenarios for practical application of knowledge. Group discussions of complex cases, enhancing collaborative learning. Facilitated online discussion boards, fostering interactive engagement. 2 mock exams with detailed answers were used for self-assessment. Personalized feedback and one-on-one assessments are available upon request. Optional one-to-one guidance with extra support. The greater than 40 hours course encompasses lectures, over 2,000 MCQs, and an additional 10 hours for webinars, tutorials, online engagement, and interactions. Join us in emphasizing the development of effective clinical reasoning strategies rooted in the best evidence and critical reflection on practice. Take control of your exam preparation journey. For more details and to register, visit us at worldkidneyacademy.org. We look forward to supporting your journey in nephrology. Join us today and take the next step in your nephrology education.
Hello, everyone. Thank you very much for joining us today in the OSCE and Viva webinar. We're glad to have you, all of you today. We'll present you a few questions. We hope it will be helpful in your preparation for various exams in the future. You can consider this as a mock exam. Please, it all depends on your engagement today to have the perfect outcome of this webinar. We have 3 different members of our course who will present the questions, and we are expecting a full engagement from the whole platform. Till now, we have more than 60 participants already joined in. So it all depends on your participation and engagement today, and welcome on board. As to start with, I will just share my screen just now and crack on. Right. I think all of you already see my screen. Good. Yeah. Okay. Welcome again to WKA Academy's exam preparation course. Today, as we mentioned, we'll present the OSCE and the Viva exam webinar. We'll start with the transplantation courses and the transplantation questions led by our Professor Ahmed Halawa. As you all know, Professor Halawa is a consultant transplant surgeon, is academic lead and the chairman of the World Kidney Academy. Kindly, he will take us through a journey through 5 difficult questions. As I said, we expect full engagement from the platform to get the best outcome, please. So, Prof. Halawa, the platform is yours. I will skip once you're ready.
Thank you very much, Dr. Ahmed. I'm Professor Ahmed Halawa. I'm a consultant transplant surgeon, Sheffield Teaching Hospital, United Kingdom. The exam question, these ones are not difficult ones, but they are real ones. This is the best way to describe them. Real exam questions, and this is what you get in the exam. The exam is not designed to trap you, but designed to screen your knowledge, to make sure that you know. Nothing is 100% perfect. MCQ had its pitfalls as well. So we can even teach you during the course of the exam preparation program how to cover the gap and how to override the hurdles of the MCQ. So we'll teach you as well the art how to answer the MCQ. Maybe I will be pointing to a bit of this art while I'm asking the questions today. But anyway, this is, you need to practice and practice and practice and practice. Fine, so we'll start with, please, reply in the chat box. And if you are not muted, please mute yourself because, this will eliminate the background noise. So choose a correct answer regarding post-transplant AVN, avascular necrosis. To start with, before even going to the MCQ, what is the common site of avascular necrosis? Hips. Iman, well done. Hips. Muhammad, yes, yes. Fine. Does it affect other parts of the body as well? Can we have it in the neck of the humerus, head of the humerus? No, don't start answering the question now. Can we have it in the humerus? Can we have it in the head of the radius? Yes. So a vascular necrosis could come blank like this. It can affect other parts of the body. Other parts, like commonly the hip, commonly the head of the femur, have to be specific. The hip bone is different, but if you talk about the hip, you should say hip joint. Head of the radius, head of the ulna, even the head of the humerus. So yeah, it can affect many parts of the body. So it tends to occur in younger and more active age group. It can be caused by basiliximab, commonly bilateral. Radiological finding usually coincides with the onset of symptoms. So many answered C, commonly bilateral. Yes, it's commonly bilateral, but also it tends, yeah, just next hour, please. Next slide.
Yeah.
Also, it tends to affect the younger age group. Will you move to the next slide, please? Next question. Yeah. It tends to affect younger age group as well. Commonly bilateral. So if you request an MRI scan, it has to be bilateral. So you both hips. Any part who has a similar one, so you have to be, both should be screened. Yeah. Radiology, is it sensitive? Which radiological investigation is sensitive? Plain X-ray, CT scan, MRI scan. So this is how the question could come. MRI scan or bone density scan. MRI, Manan, well done. Yeah. So if you have the question about the imaging required for suspected avascular necrosis, MRI scan is the best choice. Okay, let's move on. The next one. Activation of T cells require the following except stimulation of the antigen receptor, CD28, co-stimulation, energy, CD3. So one of these answers is wrong. So in order to score high in the MCQ, you have to pay attention to the head, the exam question itself. D, we have E, D, D, D. Fine, the correct answer is, next slide please, D, yes. I mean, basically this is the wrong answer, but the correct choice is D. Shall we go back to the exam question again? Those who mark CD3 is integral part of T cell receptor. So it's not 3G3. 3G3 is involved in the process of rejection. Co-stimulation is involved in the process of rejection. CD28 is involved in CD20. Sorry, in the rejection. Let's go back to the explanation again, Dr. Ahmed. Next slide. Actually, what we do in this program, we provide you with explanation of the answer. It's not only we're teaching you to get the exam right, but we're teaching you as well the science of transplantation and nephrology. You can learn from this. This is like a revision course. Yeah. Next one. The presence of donor-specific antibodies DSA in the serum of a potential kidney transplant recipient. So we need to choose the correct answer. It can be detected in vitro by testing the recipient leukocyte and the donor serum. Can anybody admit those on the waiting list? It is a relative contraindication to kidney transplantation. It can be found in all male patients older than age of 20. Always give positive cross-match. It is an absolute contraindication to kidney transplantation, the presence of DSA. This is a tricky question, and I'm going to see now who's very smart and knowledgeable to answer it. The correct choice is, next slide, B. Yes. So let's go back to the question, Dr. Rahman. So let us analyze everything here. It can be detected in the vitro. You have to, and this is actually, you need to practice and you need to learn in order to answer the MCQ properly. It can be detected in vitro testing with the recipient leukocyte and donor serum. What's wrong with it? Yeah, why this statement is wrong? Recipient serum, well done. Who did that? M.E. Mohammed Dermi. Excellent, excellent, excellent. Yes. It's other way around. It has to be recipient serum and donor cells. It's a relative contraindication to kidney transplantation. Yes, this is correct one. It can be found in all male patients older than age of 20. What's wrong with it? Keep admitting, admitting colleagues, please. Male under the age of 20. Zeb, yes, Ahmad Zeb. Yeah, YL and Wali is yeah. All is wrong. Excellent, excellent. This is one of the techniques of answering the MCQ. I'm going to explain it. No age. Fine. It's unlikely for males to be sensitized. Simply, unless blood transfusion or transplant. Usually, females will get sensitized to pregnancy. And when you see the word all, I will think it must be most likely is wrong. Fine. Option D always gives positive cross match. What do you think? Why is wrong? Always is wrong. Excellent. From the science point of view, why is it wrong? Forget, always. So if I said it gives positive cross match. No answers? Let's explain it to you. Don't worry. If you have DSA, donor-specific antibodies, In order to have a positive cross-match, you have two things: donor-specific antibodies and the HLA. The donor-specific antibodies is against the recipient HLA. I'm sorry, the donor HLA, because donor kidney or organ will be transplanted. And if you don't have the HLA counterpart, so DSA is doing nothing. It can't interact because the related HLA antigen is not there. Also, there's a cutoff for the cross match. If the DSA is still present, but below the cutoff, it wouldn't give positive cross match. The word L always attracts attention. It is absolute contraindication to kidney transplantation. What do you think? Why it's wrong? Well done. The word absolute as well makes you suspicious. What else? Science-wise. Because you can desensitize and transplant. Not only that, what else you can do? You can transplant if the cross-match is negative and the DSA level below the cutoff. So we'll go back to the relative contraindication of kidney transplantation. When you answer the MCQ, don't jump into the right answer straight away. What you need to do is elimination technique. This is wrong, this is wrong, this is wrong, this is wrong. You'll be left with the correct answer at the end. Let's move to the next. Mr. Rama, please. I think we answered this question. The fourth question, one or more of the following is an indication of desensitization. Yeah, Henry, well done. Which one of the following is indication for desensitization? Positive B and T cell cross-match, poorly matched kidney, the presence of DSA and MFI above 1000, previous transplantation, all of the above. Look, I trapped most of you, except, this is wrong. It's one answer needed. All the exam questions you have, and in the fellowship exam, is one best answer. Except Ammar and Ali, who said A. Of course, the chance of an exam question with all of the above and none of the above, that all of the above or none of the above will be the correct answer. And if you have all of the above or none of the above, the chance of the all of the above to be more correct than none of the above. But I made this exam question just to trap you, because you should not rely on this, because never 100% perfect. You should rely on your science and your practice. Let's go to why. So the correct answer is B and T cell cross-match positive. Yeah. let's go back to the question, Dr. Ahmed, if you don't mind. Let's analyze this one.
Oh, sorry.
Why poorly matched kidney, you know, not get desensitization? Desensitization is all about DCA and HLA, nothing to do with the quality of the kidney. The presence of DCA and MFI above 1,000. Okay, the DCA could be non-complement fixing and not causing positive cross-match. Why did it desensitize? It's completely wrong. Previous transplantation, so what? Previous transplantation provided that there's no DCA, provided that cross-match is negative, no need for desensitization. Therefore, all of the above is wrong because, you know, few wrong answers here. So let's move to the next then, please. My last MCQ question. There are numerous toxicities and adverse effects associated with immunosuppression. Which of the following statements is true concerning complications of immunosuppression? Transplant recipients are susceptible in the first month to infection with opportunistic organism. Immunosuppressive agents may blunt the inflammatory response to infection, leading to late presentation of an infectious process. The development of malignancy appear primarily due to direct mitogenic effect of the agent. Lymphoma are the commonest malignant tumor developing in transplant patients. Graft versus host disease is a progressive condition and extremely difficult to treat. Which one is the correct statement? We need only one. I mean, just to make life easy for you. Fine. So the correct answer is, move to the next slide, B. So who did answer B here? Who said one correct answer? Yeah, Dr. Muhammad Sheikh Hassan, Saeed, Jamila, Soshma, well done. Many actually. I'm impressed with Henry. Yeah. Fine. So let's go back to the exam question and analyze it. Back. One of the rules of, cracking the MCQ. If you have a long statement, the long statement most likely, but not exclusively correct. So the longest statement here of the 5, this one B. So I would think it could be correct. Because examiners tend to put on more effort in explaining the correct answer. But this is not a rigid rule, by the way. So let's analyze it. Transplant recipients are susceptible in the first month to infection with opportunistic infection organism. Why it is wrong? In one word? Yeah, well done, Tarkil, well done, yes. Usually after the first month, not during the first month. We agreed immunosuppression, this is a straightforward correct answer. Immunosuppressive agent blunt the inflammatory response. This is what the immunosuppression is for. The development of malignancy appears primarily due to direct mitogenic effect of the agent. Why it is wrong, scientifically? Any smart answer? Yeah, okay, Osama. Yeah. But now the question in that AB, excellent, excellent. It's a viral driven malignancy, mainly. We'll talk about EBV and even CMV and all other viruses, papilloma viruses, all sorts of things, hepatitis C, all these viruses. So it's a viral-driven malignancy. Yeah. Lymphoma are the commonest malignant tumor developing in transplant patients. Skin cancer, well done, straightforward. Graft versus host disease is progressive condition and extremely difficult to treat. If I don't know anything about graft versus host disease, and also I'm sure that immunosuppressive agents, the option B is most correct. Of course, I would choose option B. So elimination. We will keep this till the end. Then you compare it with this one. This is a longer sentence, option B compared to this one. Science-wise, is not extremely difficult to treat and is not common in renal transplant recipients. Yeah, thank you very much. So this is a sample of the transplant MCQs. We have more than 250 MCQs similar with variable difficulties, but it's important to learn and practice. Learn and practice. You have to learn the technique. Knowledge is not enough. Thank you.
Thank you, Prof. Ahmed, for your and thank you, the participants, obviously, for your engagement. That's extremely helpful. To the next speaker will be Dr. Rami. He will present to us a acid-base balance and electrolytes top tips and prepare for the difficult part. Would you like to share your screen, Rami?
Yeah, please, Dr. Ahmed. Thank you.
Thank you. I did unshare mine.
Okay. Is it clear now?
Yes, full screen, please.
Oh, okay. I want to use pen. Just 1 second. Okay. First of all, I would like to thank my colleagues and my professor to stay with us today in this webinar. And I would like to thank Dr. Ahmed Dr. Ahmed Halawa for this elegant presentation about some of our MCQs. And I would say impressed about how much MCQs we have in this course covering all the spectrum of nephrology. I'm really surprised of how much is the effort done for this course. And I would like to invite all of us to join this course because, as we saw all, you can imagine 5 questions and we got all this information. So how much is the information we will got from 2,000 questions with MCQ, you will cover most of nephrology. So today I would like to discuss and to just revise with all of us some of EPG. We all nephrologists, so we have all of us. We have the knowledge, and we exposed in a way or another to this APG during our clinical practice. So please, if you don't mind, just open your calculator on your phone and try to follow me during this presentation. So we have question number 1. We have a patient. This is parameters we have. His pH is 7.232, and bicarbonate is 15, and PCO2 is 30, and anion gap is 20. And what do you think, what kind of acid-base balance disturbance we have? This is a simple question we are usually facing during our clinical practice and even in exams. And to answer this question, I will take you in a journey how to answer the question simply without any complication or to miss the question answer. So we have 6 steps in interpretation of acid-base balance. Step 1, we have to comment, is it acidosis or alkalosis? And step 2, you have to comment, is it a respiratory or a metabolic primary lesion? Step 3, if it is respiratory, we have to comment, is it acute or chronic? And I want to stop just for 1 second in this point. We only comment, is it acute or chronic, if the primary insult, it is respiratory only. So we are not commenting in this if the primary insult, it was metabolic. And we will get the explanation of this, this point later. Step 4, if we have a lesion, so we have to mention the compensation, is it adequate or not? Step 5, if we have a metabolic, we have to comment on anion gap. And if we have high anion gap, so it will be, we have to mention, just 1 second, remove this one. So just yes. Okay, so if we have high anion gap metabolic acidosis, we have to comment on delta. But on the other side, if we have a normal anion gap, we have to comment on urine anion gap and urine osmolar gap, and we will go step by step. Don't get panicked. ABG is simple, and we will take step by step. So go back to our question we have. And first of all, I want to remind you by normal values. So we will consider pH 7.5 normal or a corrected one. Bicarbonate, the average is 24. PCO2, the average is 40. Anion gap, normally it is 10. Delta gap, which can be calculated by calculating delta anion gap minus delta bicarbonate, and it's usually 0. If it is positive, this means we have a mixed metabolic alkalosis. On the other hand, if it is negative, so we have a high anion gap metabolic acidosis mixed with a normal anion gap metabolic acidosis. And from clinical practice, and usually I'm seeing my colleagues have a problem regarding delta gap, because you usually forgot who is metabolic acidosis and who is metabolic acidosis. Just to give you a tip, if you have a negative, so it is acidosis because C coming before L. And if you have a positive delta, so it is a metabolic mixed with metabolic alkalosis because L is coming after C. So back to our question, we have a patient with pH 7.232, and we have bicarbonate. Sorry, I have, yeah. So bicarbonate is 15, and PCO2 is 30, and anion gap is 20. So we mentioned before we have 6 steps. Step 1, we have to comment, is it acidosis or alkalosis? We mentioned in the previous slide that normal pH is around 7.4. So it is lower than the normal value. So is it considered acidosis or alkalosis? Just reply in the chat, please. Dr. Ahmed, if you don't mind, can you just follow the chat, please? Yeah, sure. So first of all, yes, magnificent. All of us knows this is metabolic acidosis. It's acidosis. For second point, is it respiratory or metabolic? So we have to look for both numbers for bicarb and PCO2. Bicarbonate is 15, so this is acidosis, which justifies the pH. On the other hand, PCO2 is 30, which is below the normal, which is 40, and this is alkalosis. So it doesn't justify the pH. So it is a compensation. So we can expect now we have an acidosis, and this is justified by low pH and low bicarb, and we have metabolic acidosis. And as long as we have a anion gap 20 and the normal value doesn't exceed 10, so we have high anion gap metabolic acidosis. So this is step one. And as long as we mentioned before, it is metabolic acidosis, there is no need to comment, is it acute or chronic? Because also this is a common mistake from my young colleagues. They are always confusing about commenting in acute or chronic in metabolic abnormality, which is usually done only for respiratory. So what is the next step? As long as we have high anion gap, so as long as we have high anion gap, we have to comment on delta. And as we mentioned, we have delta bicarb, which is 9. How we get this 9? We subtracted normal value of bicarb, which is 24, and the value in the equation, which is 15. So 24 minus 15 is 9. So we have delta bicarbonate is 9, and we have delta anion gap is 10. How we get this 10? We subtracted 20 minus 10, which is we have in the equation. So we have delta anion gap is 10. So we can see delta bicarb and delta anion gap, it's almost the same. It's 9 and 10. So we don't have any other lesion because as we mentioned, if the delta bicarb and delta anion gap is the same and equal 0, so we don't have any another lesion. So only we have here high anion gap metabolic acidosis. The next step, step 4, regarding compensation. All of us are nephrologists. So most of us are exposing in daily basis for metabolic acidosis because most of our cases are renal diseases. Renal patient has a metabolic acidosis for a reason or another. So we are usually using this equation. Most of us using a lot of equations, like we are using expected PCO2 is bicarbonate multiplied in 1.5 plus 8. But I used this equation just because it's simple. So for expecting the respiratory compensation, delta BCO2 is 1.2 multiplied in delta bicarbonate. So we have delta bicarb, we already calculated, which is 9. 1.2 multiplied in 9, it is 10.8, which is almost 11. So usually the number of, I will use pen here, just 1 second. So let's say the normal value of BCO2 is 40, and we expected a change in PCO2 to be 11. So it should be the difference, it will be 40 minus 11, it will be 24. So if we have a normal and a proper respiratory compensation, we are expecting our PCO2 to be 24. And if we go to our equation, it is 30. So it's almost the same. So it's a proper compensation. So we can now exclude the final diagnosis is we have here high anion gap metabolic acidosis, high anion gap metabolic acidosis, and with appropriate respiratory compensation. This is simply what we are using in daily practice. And our main problem is we are not going in a proper algorithmic pathway. So it's because it should be step 1, acidosis or alkalosis. Step 2, we have to comment, is it a respiratory or a metabolic? Step 3, only in respiratory disorder, we have to comment, is it acute or chronic? If it is metabolic, there is no value of this step. Step 4, we are going to say as compensation. So we just mentioned now one of the equation for compensation. If we have a metabolic acidosis, just remember this equation. The respiratory compensation in metabolic acidosis, we have delta PCO2, which is equal 1.2 in delta bicarb. Okay, so let's go for the second. This is the equations we are using for expected PCO2. So as I mentioned before, just 1 second to clear this drawing. Okay. So as we mentioned, most of us are nephrologists, so we are exposing to metabolic acidosis all the time. So delta, for every change in bicarbonate 1 millimole, we will have 1.25 change for PCO2. So delta PCO2, it will be 1.2 multiplied in delta bicarb. This equation is the simple for metabolic acidosis, but we are not usually exposing, or we are not seeing metabolic alkalosis all the time, but we have to memorize this number. So for metabolic acidosis, we multiplied in 1.25, but for metabolic alkalosis, we are multiplying in 0.75. I hope it will be clear. So question number 2. We have pH 7.1, bicarbonate 6, PCO2 20, anion gap is 20. So what do you think? Step 1, is it acidosis or alkalosis? Answer in the chat, please. Okay, so excellent. The answer, the proper answer, we have an acidosis. Step 2, is it a respiratory or a metabolic one? So look for the value of bicarbonate and value of PCO2. Bicarbonate is 6, which is justifies the acidosis, and PCO2 is 20. So it is CO2 wash, which is justify an alkalosis, which doesn't match with the pH. So what do you think is what is the primary insult happened here in this case? Perfect. So we have a metabolic acidosis. Step 2, we finished. So let's go for step 3. Do we need to do an acute or chronic assessment? No, there is no need to do, because we have a metabolic acidosis. Excellent. So as long as we have a metabolic acidosis, we have to comment an anion gap. So we have anion gap here is 20. So what do you think about this anion gap? It's a high anion gap. And we all agreed, once we have high anion gap, we have to go for delta. We will mention this during the course, and this is just a brief about acid-base balance, why we need to do delta, because it's sometimes we have another lesion and it can be used for diagnosis of underlying lesion. So as long as we have high anion gap metabolic acidosis, only in high anion gap metabolic acidosis, we have to do delta. So let's go simply one by one. So step, don't forget this map, because you will need it in every single equation. So as we agreed, we have high anion gap metabolic acidosis. And we agreed there is no need to see, is it acute or chronic? So we have to look for delta. Delta bicarbonate is 18 and delta anion gap is 10. And I will just stop for 1 second and I want to put another comment. Usually, I'm seeing, because this is a very common mistake from our colleagues, so I will just put a comment on it. It's the equation is anion gap minus bicarb, not the difference. So if you reverse it, it makes a positive negative and negative positive, so don't do it. So as long as we are looking for delta gap, we have to put the anion gap at the first. So let's see, we have a negative value or a positive value. So we have anion gap here, which is 10, minus bicarbonate, which is 18. So we have a positive value or negative value? Please answer. Negative value. So we agreed, as long as we have a negative value, so it will be high anion gap metabolic acidosis mixed with, answer, please, metabolic acidosis, not a metabolic alkalosis. And this is, as I mentioned before, it's one of the common mistake. We have to remember, as long as we have negative charge, it will be mixed with metabolic acidosis, normal anion gap metabolic acidosis. And if it is become a positive charge, it will be high anion gap metabolic acidosis mixed with metabolic alkalosis. I hope it will be clear now. So, okay. So let's go for the answer. So we have high anion gap metabolic acidosis mixed with normal anion gap metabolic acidosis. And we all now remember why acidosis, because it's negative charge. Let's go for compensation. It's the same equation as long as we are speaking about metabolic acidosis. So delta BCO2, it will be equal 1.2 multiplied in delta bicarb. So 1.2 multiplied in 18, it will be 21. So the change, it will be 21. So we are expecting BCO2, it will be 19, which is almost the same number. So we have here high anion gap metabolic acidosis mixed with normal anion gap metabolic acidosis with appropriate respiratory compensation. Question number 3. Give me just 1 second. I will clear this. Yes. Okay. So let's go to question number 3. We have a patient with pH 7.38, bicarbonate is 20, PCO2 is 35, anion gap is 26. What do you think about this acid-base disturbance we have? So let's again go to the 6th step in commenting on APG. Is it acidosis or alkalosis? It's acidosis, yes. So yes, it's normal pH, as some of us replied, but as you can see, it can be corrected. So we have a lesion because we have a disturbance in bicarbonate and PCO2, but it's corrected. So it's almost normal, but there is still a change. So we have an acidosis. This is step 1. Step 2, is it a metabolic or a respiratory? We have bicarbonate is 20, and we all know normal range is 24, and BCO2 is 35. So we have here an respiratory compensation, which is justified by PCO2 wash. And we have here a loss of bicarb, which justifies this pH. So what do you think? Is it a metabolic or respiratory? It's a metabolic. Excellent. So we have a metabolic acidosis with some of respiratory compensation. So as long as we have a metabolic acidosis, we have to look for anion gap. So again, we have anion gap here is 26. What do you think about this anion gap? We all know that anion gap should be 10. So it's more than 10. So it is high anion gap metabolic acidosis. Excellent, perfect. So step 1 and step 2 and step 3, step 4 about compensation. How to get the number of respiratory compensation? We can see here. let's let's skip this about respiratory compensation. So we are expecting our delta PCO2 to be 1.2 multiplied in delta PCO2. So we are expecting we have a change about 4.8 from the normal reference. So it's we are expecting PCO2 to be 35. So we have a proper respiratory compensation. So as long as we mentioned before, as long as we have high anion gap metabolic acidosis, we have to do delta delta. Delta delta, we have delta bicarb is 9 and delta anion gap is 16. So we have here this high anion gap is higher than delta bicarb. So if we did the equation, delta anion gap, just I will bring a pen. So as we agreed, anion gap, delta anion gap minus delta bicarb. So 16 minus 3, it gives you a positive charge or a negative charge. Positive charge, excellent. So as long as we have a positive charge, so we have a combined high anion gap metabolic acidosis with metabolic alkalosis. And we all remember now, I will never forget, as long as delta delta is a positive charge, so L coming before C. So if it is negative, it will be mixed with a normal anion gap metabolic acidosis. If it is positive, it is mixed with high anion gap with metabolic alkalosis. So the final conclusion of this case, we will have here high anion gap metabolic acidosis with metabolic alkalosis and with appropriate respiratory compensation. So I think it will be more complicated, just be focused. And as long as you are following this process, you will never get lost in equations of EBG. Let's go for question 4. We have a patient here. He has pH 7.2, bicarbonate, BCO2 is 40, bicarbonate is 15, anion gap is 20. And you was asked about what is the acid-base disturbance. Now let's go step by step. Step 1, acidosis or alkalosis? Metabolic acidosis. Acidosis. This is step 1. Step 2, is it a metabolic or respiratory one? Let's go for these numbers. We have PCO2 is 40, and we have bicarbonate is 15, which is justify acidosis, which is we have in this pH. So we have here a metabolic acidosis. As long as we have metabolic acidosis, we have to look for anion gap. So again, anion gap is 20. So what do you think about the lesion here? Excellent. We have high anion gap metabolic acidosis. And as long as we have high anion gap metabolic acidosis, we have to look for delta delta again. So we have delta delta, delta bicarbonate is 9, and delta anion gap is 10. So it's almost the same. So we have only high anion gap metabolic acidosis. What about compensation? Same number. We have to calculate 1.2 multiplied in delta bicarb, so multiplied in 9. So the appropriate PCO2 should be 29, but in this patient, we have PCO2 is 40. So we have, this patient has a lung lesion. He has some kind of inappropriate respiratory compensation. So our conclusion, it will be, we have a mixed anion gap metabolic acidosis. Either you can say with inappropriate respiratory compensation, or you can say with another respiratory acidosis. Okay, so let's go for question 5. pH 7.5, PCO2 is 20, bicarbonate is 15. And what do you think, what is the acid-base disturbance you have? So step by step, step 1. What do you have here? Excellent. We have alkalosis. Step 2, is it a metabolic or a respiratory one? Look for PCO2. We have PCO2 wash here, which is justifies the alkalosis. on the other hand, we have bicarbonate 15, which is cause acidosis. So this is a compensation. So we have here a respiratory alkalosis. And here's the first time we are applying step 3. We have to look, is it acute or chronic? Okay, so let's go and see how to comment, is it acute or chronic? So why we need to comment in respiratory insult, is it acute or chronic? Because we have two main organs in regulation of acid-base balance. We have kidneys, which is for correction, it takes a longer time. On the other hand, we have a respiratory system, which is compensate very quickly. So if we have a metabolic lesion, we are expecting the respiratory system to compensate very quickly. And this will help the patient a lot. But if the patient has an acute insult in the respiratory system, and his kidneys couldn't compensate in a proper way, he will need another support. So let's say if we have a patient with an asthma or a COPD, and if you find his correction of he has an acute insult or a chronic insult, your decision, it will be completely different. Because if he has acute insult and you can see this kidney will take a longer time for correction, this means he will need another support like a ventilator or something. It's the opposite decision if this is a chronic lesion, like an asthma or something. So you have to decide if this patient has an acute insult or a chronic insult. So let's go for how to decide, is it acute or chronic? So we have here in our equation, we have pH 7.5 and PCO2 is 20. And we have to figure out, is it acute or chronic? So step 3, commenting in acute or chronic, and step 4, looking for the compensation. So we have a respiratory lesion, and we have to look for the metabolic correction. So we need to see the expected PCO2. I revised all the equation, but I just came with a simplified one. If you are expecting if we are facing an acute insult, the change in bicarbonate in the opposite to each change in PCO2, it will be 0.2. So if we have an respiratory acidosis and PCO2 accumulated for each 1 millimeter Hg for PCO2, you will have 0.0 milliequivalent change in bicarbonate. And for chronic lesions, for chronic insult, you will have a change 0.4. So for every 10, you will have 1 change. This is for acute. And for chronic, for every 10, you will have 4 change in bicarbonate. So simply, this is a simple equation. So let's go back to our equation. So if this patient has an acute respiratory acidosis, we are expecting his bicarbonate to be should be 20. Because how we get this 20? We for he has a change in PCO2. His normal range is 40. Let's get a pen to just verify. Okay. So normal range of PCO2 is 40. And we have here is 20. So you have a change 20. Okay, so for each change of 10, we will have in acute, it will be 1. In a chronic, for every 10, you will have 4 change in bicarb. So we have 20 change. So we are expecting change in bicarb. In acute situation, it will be 2. But in chronic situation, it will be 8. I hope it will be clear now. So if it's acute insult, we are expecting a change. It will be 8. If it's chronic, sorry, it will be just 4. Sorry. So, and we are expecting 4 if it is acute. Let's go for our patient. This clear all the drawing. So let's see our patient, what happened to him. His bicarbonate is 15. So how much change he was having from 24? So usually we have bicarbonate is 24. And now he has 15. So how much change he have? It is around 9. So if this patient has an acute insult, it will be 20. But if he has a chronic insult, it will be 16, as we mentioned before. So we are expecting 16, but he has 15, so he's almost have a chronic insult. So this patient has simply a chronic respiratory alkalosis. So it's a little bit tricky, but as I mentioned before, it is only used in respiratory insult. So whatever alkalosis or acidosis, if it is chronic, we are expecting for each 10 change in PCO2, we will have 4 change in bicarbonate. If it is acute, for each 10 change in PCO2, we will have 2 change in bicarbonate, and vice versa. So let's go for compensation. As we mentioned, the same equation, nothing changed, nothing new. We already mentioned if there is an acute change, we will use 0.4. But if it is acute, it will be 0.2. If it is chronic, it will be 0.4. So we are expecting a change in bicarbonate, it will be 8, which is appropriate in this case. So we have a proper metabolic compensation. So we have in this patient chronic respiratory alkalosis. And as I mentioned before in the steps, as long as we have a respiratory insult, there is no need for doing anion gap calculations. There is no anion gap, there is no delta delta, there is nothing. So this is your final answer. So one of the common mistakes, which are usually seen by young colleagues, once they are going in the process, they are trying to calculate the anion gap and delta anion gap even in the respiratory lesions, and this is inappropriate. Okay, I hope you're still with me because خلاص we are almost finishing. So let's go for question number 6. We have a pH 7.61, bicarbonate is 30, PCO2 is 30, bicarbonate is 29. What kind of acid-base disturbance you have? Please answer in the chat. Alkalosis, perfect. This is step 1. So alkalosis, we have respiratory or metabolic. This is a tricky question. Because, if you figure out this is CO2 wash, so we have a respiratory alkalosis, and we have also at the same time bicarbonate increased, which is metabolic alkalosis. So we have both of them. So we have metabolic and respiratory alkalosis. So whatever you decide, let's go for metabolic alkalosis. Once we mention metabolic alkalosis, we have to look for compensation. And the equation here, it will be not 1.2, it will be 0.7 because we have a metabolic alkalosis. So the expected BCO2, it will be a 43, which is we have here is 30. So we have mixed metabolic and respiratory alkalosis. This is inappropriate because we should have a respiratory acidosis as a correction for this metabolic alkalosis. Question number 7. We have a pH 7.4, PCO2 is 60, and bicarbonate is 37. What kind of disturbance you have? Step by step. Don't rush. Is it alkalosis or alkalosis or acidosis? Yes, perfect. This is an alkalosis. What do you think? Is it a metabolic or a respiratory one? Metabolic. Perfect. Okay, perfect. Because we have here PCO2, which is 60, which goes with respiratory acidosis, which is not justifying this pH. But we have on the other side, are very high, bicarbonate, which is 37, which justify our pH. So we have a metabolic alkalosis. Okay, so as we mentioned, we have metabolic alkalosis. There is no need for delta-delta. There is no need for anion gap. There is no need for acute or chronic. So we will go directly for compensation, and that's it. We finished. So we have a metabolic alkalosis. Respiratory, as we mentioned, 0.7 in delta bicarbonate. So it should be 49. So it is 60. So we have a metabolic alkalosis mixed with respiratory acidosis. Question number 8. This is our final question and the most difficult one. So please stay sharp. We have a pH 7.1, bicarbonate is 10, and PCO2 is 35. And this is our data for this patient. We have a creatinine 1.8, BUN is 38. We have serum electrolyte, sodium 136, potassium is 1.5, chloride 1.5, and bicarbonate 10. We have APG, which is not our discussion today, but we have pH 7.1, PCO2 is 35, BO2 is 110, and glucose was 132. Albumin is 4.2, and urine electrolyte, sodium, potassium, chloride, as we can see here. Urine pH is 6, and urea is 38, and urine osmolarity is 610. And we have 2 questions here. Question number 1, what is the underlying acid-base disturbance? And question number 2, if we have any underlying renal tubular acidosis. So again, don't get panicked. We have a simple question here, and we will go step by step. So what kind of insult we have? Is it acidosis or alkalosis? Step 1. So we have acidosis. This is excellent question. So we have acidosis. Is it a metabolic or a respiratory insult? We have bicarbonate 10 and BCO2 is 35. So metabolic or respiratory. Excellent. This is a metabolic acidosis. So as long as we have a metabolic acidosis, we have to go for anion gap. This time, he didn't give us the anion gap. He asked us to calculate the anion gap. So let's calculate the anion gap. Anion gap, as we all know, sodium minus chloride plus bicarb. So we have chloride and bicarb 105 plus 10, 136 minus 15 and plus 10, so 21. So we have anion gap 21. What do you think? Is it normal anion gap or high anion gap metabolic acidosis? It's high anion gap. Perfect. So we have high anion gap metabolic acidosis. As long as we agreed we have high anion gap metabolic acidosis, we have to go for delta-delta. So delta bicarbonate is 14 and delta anion gap is 11. So 11 minus 14 equal 11 minus, is it positive or negative charge? Negative charge. Excellent, Gamil. So as long as we have negative charge, so we have high anion gap metabolic acidosis mixed with normal anion gap metabolic acidosis. So let's go for the compensation state. Stage 4, we have to look for compensation. So as when we mentioned, as long as we are speaking about metabolic acidosis, delta PCO2, it will be 1.2 multiplied in delta bicarbonate. So expected PCO2 is 23. So we have here a high anion gap metabolic acidosis mixed with normal anion gap metabolic acidosis with respiratory acidosis. So all the lesion we have. So the second question is, do we have a renal tubular acidosis? Why he's asking this question? Any ideas? Perfect. We have a good answer here. As we mentioned in our steps, I don't know if it's the previous, yes. As we mentioned, step 1, looking for acidosis. Step 2, respiratory or metabolic. If we have a respiratory lesion, we have to look, is it acute or chronic? Step 4, looking for compensation. If we have a metabolic, we have to look for anion gap, which is we already did, which is 21. If we have high anion gap metabolic acidosis, we have to look for delta, which is we already also did, and we found that we have normal anion gap metabolic acidosis. So as we mentioned in our chart here, as long as we have a normal anion gap metabolic acidosis, we can go for this process, for this step, which is looking for urine anion gap and urine osmolar gap. I will give you just a very quick information about the normal physiology. So I will not go for detail, just give you a hint. Once we have a metabolic acidosis, our kidney try to compensate by generating a bicarbonate. And to do this process, it has to metabolizing glutamine and excreting ammonia. So normally, if we have acidosis, our kidney try to compensate by forming bicarbonate. This is normal. And from this process, kidney will excrete a lot of ammonia. So we have to have a lot of ammonia secreted in our urine. This is normal. But if we have a renal tubular acidosis, this kidney will not be able to do this process. So we will have a low ammonia in our urine. Usually, we are not calculating ammonia, but we are calculating it indirectly by using urine osmolar gap. If you divide urine osmolar gap by 2, it will give you an idea about how much ammonia is secreted in our urine. This is simple information. So we use this information to justify our knowledge. And also, you have to know, if we have high ammonia excreted in our urine, it will reflect also, we will have high chloride excreted in our urine for the charge. So if we have high ammonia excreted in our urine, this is normal response from our kidney for the cases of metabolic acidosis. Kidney trying to compensate by metabolizing glutamine, secreting ammonia, which will be measured by using urine osmolar gap divided by 2. And also in the same time, if you have high urine ammonia in your urine, you will have high chloride. So from this normal physiology information we will have, it will reflect in our practice. So for normal anion gap metabolic acidosis, we have 2 main differential diagnosis, which is related to diarrhea or renal tubular acidosis. So we have to differentiate. So how to measure urine anion gap? We all know the equation of serum anion gap. Serum anion gap equals sodium plus potassium minus a combination of bicarb plus chloride. And most of us not using potassium because it's very low in our serum. It's always 4, so it doesn't make it a huge change in the equation. But in the urine, the picture is different. It is the same equation, but as you can see, potassium is respected. So we have to look for the urine in the potassium in the urine, and we are not expecting to see bicarbonate in the urine. So bicarbonate is not in the equation. So the equation, it's the same, but slightly modified. The same equation we are using for measuring the anion gap in the serum, but sodium plus potassium minus chloride. So as we mentioned, if we have high ammonia excretion, which is normally if you have a normal kidney, so if you have high ammonia, you will have high chloride, which is making the equation negative charge because the chloride will be very high, and it will be exceeding the combination between sodium and potassium. This means you have a normal kidney and normal response for metabolic acidosis, and this is only can be justified by diarrhea. On the other hand, if you have a renal tubular acidosis in your patient, and you are expecting his kidney is not appropriately responding to this metabolic acidosis, so his concentration of urinary ammonia, it will be low, which is make the chloride also low, so his urine anion gap, it will be positive charge. So again, and in this course, we will try to give you some tips to remember the information. So if you have high chloride, which is seen in normal anion gap metabolic acidosis justified by diarrhea, you will have negative urine anion gap. And just to make you remember, diarrhea, it means losing fluids using your body fluids. See, you will have negative urine anion gap. As long as your kidney is normal, so it's excreting a lot of ammonia, so you are losing a lot of ammonia. Just as simple, just I'm trying to help you to remember this information. So if you have a normal anion gap metabolic acidosis, and you want to see if this patient has renal tubular acidosis or not, you have to go for anion gap. If you have positive anion gap, which is not justified, your kidney should not have should have excreting a lot of ammonia, and you should have a high chloride in your urine, and your urine anion gap should be negative because chloride is high, which is not happen in renal tubular acidosis. And at the same time, your kidney excretion of ammonia is low, so you are expecting excretion of ammonia is below 200, which is again subnormal for this abnormality. So going back to our case, we have to know if this patient has renal tubular acidosis or not. First information from physiology, we can go for chloride. If we have high chloride, this by mean will reflect on anion gap. It will be positive in diarrhea, and it will be negative in diarrhea, and it will be positive in renal tubular acidosis. So from this case, we will have chloride 65, which is lower than the assumption between sodium and potassium, and give you a positive charge urine anion gap. So there is no renal tubular acidosis. And there is another way from calculation of urine osmolar gap. Also, I want to remind you about serum osmolarity. In our serum osmolarity, we are using this equation, which is equal sodium 2 multiplied in sodium, glucose divided in 18, blood urea nitrogen divided in 2.8. And I want you, it's most of us not recognizing that all the elements used in this equation are the same elements we are facing in our clinical practice, and usually not we are advising our juniors not to make a huge change in correction. So for sodium correction, we are doing a very slowly correction, because if you did a very quick correction in the sodium, it will cause pontine demyelinosis. In the same time, if you did a very quick correction of glucose, it will cause a brain edema. And at the same time, if you make a huge correction in urea, which is usually seen in dialysis patient, it will cause disequilibrium syndrome. And as you can see, every single element of this equation, if you did a huge or rapid correction, it will be associated with a neurological manifestation, because all of them are connected to the osmolarity. And if you change the osmolarity very quickly, you will have a brain insult and you will have a neurological manifestation. This is the same equation we are using to calculate the urine osmolarity, but as you can see, again, we are respecting potassium because urine potassium is very high. And usually we are not seeing a glucose a lot in the urine. So as we mentioned, to measure the ammonia, which is reflect the glutamine metabolize, which is reflect the kidney ability to metabolize and to secrete bicarbonate, you have just to calculate the urine osmolar gap divided by 2. And if it is less than 200, so you have renal tubular acidosis. So let's go for our case. Our case here, his urine osmolar gap, as we can see, urine osmolarity calculated is 173, and he gave us in the equation in the question his urine osmolarity, which is 610 minus the calculated one. The difference is 436 divided by 2. So this patient has ammonia in his urine almost 218, This means his kidney is excreting a lot of ammonia, and his kidney is normal, and it is responding very nicely to this metabolic acidosis, and she is trying to secrete a lot of bicarb to correct this metabolic acidosis, so this patient has no renal tubular acidosis. And thank you. I hope I tried to simplify as much as I can, but you know, even the last drawing is making a smile face. I don't know if you...
Thank you, Rami. It has been fantastic presentation. I truly enjoyed it very much, and I'm astonished that we still have the same number of participants. No one has left. So well done. Thank you very much. I will try to share my screen. If you unshare your screen, please, Rami.
Yeah, sure.
And
Okay.
and also I'll try to be as quick as we can. I think, yeah, I know it's weekends and everyone need to maybe go as soon as possible. So can you see my screen?
Yeah, very clear, Dr.
Perfect. Thank you. Thank you, Dr. Rami. Okay, I'll just open the chat so I can follow a wee bit, but I will leave the admission to yourself.
Yeah, sure.
That's okay.
Yeah, sure.
Meeting group. Yeah, all right. Right. I will share a few questions about glomerulonephritis and general nephrology questions as well. So let's go ahead. As you can see, it's a 68-year-old gentleman presented to the ED with abdomen pain, nausea, vomiting, diarrhea. On more history, taking 2 weeks of erythematous rash, which you can see a picture of in the presentation. Arthralgia, low-grade fever, more or less constitutional symptoms, high ESR and mild CRPemia, essentially with a numbness and tingling of the distal right hand and wrist area. Urine analysis, urine dip is absolutely normal. However, a bit of AKI, I would say, creatinine of 2.2, and for those practicing in the UK, one usually around 80, so it will be around 200. The rest of immunology screen is negative, including ANA, ANCA, and rheumatoid factor. So what are your options here? Okay, so excellent. So for sake of time, I will go ahead. Yeah. Some
We
of
have
yourself
a lot of
B, some other A,
Yeah,
but the most are around D,
yes.
which is correct. So the reason is this is polyarthritis nodosa, and the main thing about this question, these type of question really in the exams is pretty, I would say, for example, for the specialty certificate exam, the UK one or the European one, I would say it will constitute about 25%. It's a spot on. So there is a picture, it's very common with the background, this rash, you just should answer it with just looking into the picture with a bit of maybe questions, some on the stem of the questions as well. So back to the question, this patient has a tender, hyperpigmented, firm subcutaneous nodules with a bit of background livido reticularis. I know that maybe livido reticularis may not have been very visible in the picture, so I apologize for that. However, the stem of the question can give you a bit of that the patient had a bit of constitutional symptoms for about 2 weeks. The main issue here is the asymmetric peripheral neuropathy, and obviously mixed with the rash and with the AKI, and the patient might have a plus or minus some hypertension. This all should drag your attention toward PAN, polyarthritis nodosa. Thank you. Okay, another spot on. So a young gentleman presented with a history of sinusitis, which has been unresponsive to the treatment recently developed this deformity, which shown in the picture with a bridge of nose. He complains about anorexia, again, low-grade fever, sweats, general arthralgia, productive cough, which has sometimes been blood tinged, and a urine analysis showed active urinary sediment with red cells cast. What do you think the CT of his chest will show?
We have an excellent candidates, Dr. Ahmed. A lot
Excellent.
of these.
Perfect. That's what we want to hear. Perfect. So multiple pulmonary nodules, and some started to even jump to the next question. That's even perfect. So yes, the CT will show multiple nodules, which is consistent with saddle nose. Perfect, Mohammed. Thank you. So the radiographic appearance of the septal perforation, which the arrow here can guide you through it, explain the saddle nose deformity. Which of the following is most likely the antibody finding in this patient? Is it NA, Cianca, Pianca, or if you would like to, MPO or PR3, a positive double-stranded DNA or IL antibody will be negative. Okay. Sarah, Zainab, 1, 2, 3, 4, Dr. Ammar. Excellent. Perfect. So yes, absolutely right. Positive C-ANCA, which is consistent with PR3 ANCA, if you would like to name it this way. Right, so this patient had actually a kidney biopsy. And what would be the most likely the diagnosis here? Abdullah D. Good Pastor. B. Galaxy. Mohammed B. Tornada. Dr. Ammar. Excellent. Yes, it is GPA. Granulomatous with polyangiitis. This biopsy is quite obvious for a granulomatous vasculitic picture, which is consistent essentially with granulomatosis polyangiitis. And these patients will have a C-ANCA or PR3 ANCA vasculitis in their immunology screen. About 7 of 8 patients will have this, and it's very useful for monitoring as well during the treatment phase. The initial symptom usually is respiratory tract infection, as nose, sinuses, lungs. They can bleed, they can have a nosebleed, they can have obviously all the respiratory symptoms as cough, hemoptysis, short of breath. Okay. So now moving to what are the most important risk factors in the development of cast nephropathy? The answer became slightly slower now. Seems that the participants would like more GN. D, E, A. So I would say we don't have a consensus here. C, D. So all right. So let me read loudly the answers or the MCQs. More than 60% of bone marrow plasma cells and more than one focal bone lesion on MRI. That was number 1. Anemia or hypercalcemia. Is that the most important risk factor? If you remember Professor Halawa's a presentation about how to crack the MCQ, just have another look on the most important risk factor in development of cast nephropathy. Lytic lesions, serum free light chain level more than 50, and high urinary free light chain excretion, and the use of non-steroidal anti-inflammatory drugs and intravenous contrast agent. Perfect. Okay, so the answer is D. Okay, back to the question. So the answer is actually 3 serum-free light chain levels more than 50 milligram per deciliter and high urinary free light chain. It's very important based on very recent guidelines. These will give you an idea how to predict the development of AKI and cast nephropathy. So it's pretty important to have the free light chain pre and during monitoring of the treatment of such patients. Now, which of these is most helpful in predicting the recovery of a function, of the renal function, after cast nephropathy? Okay. Perfect. Yes, the answer is C. So the recovery of the renal function is predicted by the reduction, as a follow-up for the previous question, of the free light chain. So it's pretty important to know what is a patient-free light chain before starting treatment, because it will help you to monitor the treatment as well. What percentage of patients with monoclonal immunoglobulin deposition disease also have symptomatic multiple myeloma? This question is important one. 10, 20, 30, 40, or 50%. Okay. We have 10, we have 20, we have 40, 50. And we have 30. So again, no consensus. All right, so the answer is B, which is 20%. So there was 2 recent published studies as symptomatic multiple myeloma was diagnosed in 20% of patients with MIDD. In the course that we are providing you, we will be providing these studies, and if there is any meta-analysis as well as reference for these answers. Moving to a next one, which is, 64-year-old male patient, no prior medical history, present with hemoptysis, RPGN, found to have MPO and vasculitis. What is the mechanism of action in avacopan, which, as you know, recently has been introduced to the vasculitis guidelines? How it works? What's the mechanism of action of the avacopan? And I would be interested to know if any of the participants has an individual experience with avacopan. Okay, E, CF5B inhibitor, A, receptor inhibitor, or C5 inhibitor, or C3B inhibitor, or C1 receptor inhibitor. Tariq, Mustafa, choose A. Sushama, choose A. Iman, Ahmad, A. Right, let's go. Perfect. It's A. It's C5A receptor inhibitor. It does not inhibit the C5A itself. It inhibits or antagonizes the receptor. Okay, another question. A 72-year-old gentleman known to have a GPA, granulomatosis polyangiitis, which is similar to the patient we discussed in the first few questions. He was in complete remission after previous induction with intravenous cyclophosphamide. He was maintained on azathioprine for the last year and a half, about 18 months. He presented to the emergency unit with 1 month history of worsening short of breath, low-grade fever, dry cough. His ANCA serology repeated with a very high PR3 ANCA vasculitis, or sorry, PR3 high levels. CPC is normal. His urine showed active sediment. Creatinine is abnormal. What is the next step? We given him some methylpred. What would be the next most appropriate step? Okay, so I can see that most of the participants had chosen really the right answer, but this is not what I'm looking for only here. Why? This is a relapse? Yes. Then why you think rituximab will be better than the other options? The answer here would be just one word. Yes, it's relapse, but this is not the word I'm looking for. What guide us to take these decisions? The guidance comes from not again cyclo. Yes, why? Why we shouldn't use cyclo again? Excellent. Okay, just for the sake of the time, I will jump in because it's a relapse, and the RAVE study, which studied rituximab versus cyclophosphamide, showed that the rituximab is superior in patients with disease relapse. So this question, for example, in exams or fellowship, whatever exams you are preparing for, would come as in two main forms. Would come as, yes, what else you would be using as rituximab, or why you should be using rituximab, not the cyclophosphamide. And the answers would be different studies has been done over the last few years, and which study has supported that choice. So prepare yourself not only to know the right answer, and also the evidence behind this answer. Hope that was clear enough. Another question. A 63-year-old gentleman, RPGN features. What are the features expected on the immunofluorescence to diagnose ANCA vasculitis? Linear IgG, nothing. C3 predominance, subepithelial granulomatous IgA predominant. Perfect. It's pussy immune. Absolutely right. So there shouldn't be any uptake on the immunofluorescence. But when you have this question between 200 questions as part of your fellowship exams, it might be a bit tricky. So always go back to the basis. Yes, ANCA vasculitis are pussy immune pussy immune GNs. Right. One more question. 65-year-old CKD stage 4, non-diabetic hypertensive with stable ischemic heart disease. You come for his routine follow-up, and he complains from nausea, some decreased appetite, nocturnal leg cramps, other parameters including weight, stable. He denies any chest pain or shortness of breath or fatigue. He denies that. He's still working as a full-time attorney or a lawyer. Anyway, medication as aspirin, torvastatin, lisinopril, and metoprolol. Physical examination was essentially very well, and he's preemptively prepared for dialysis via left radiocephalic fistula well, which is very well developed. These are his parameters. What do you think the answer is for the most appropriate next step when you see such gentlemen in your clinic or CKD clinic or low clearance clinic, whatever you name it? Ooh. E, okay. D. Mm-hmm. Mm-hmm. Okay. Yeah. So I agree with you. The answer would be between C and D, whether you continue the current or you start the initiate erythropoietin. The culprit to answer this question, the writer of this question put it in between brackets. So he told you that the hemoglobin currently is 9.6. However, it was 9.2 3 months ago, and the patient is getting better. So the answer here would be continue the current regimen because the anemia is getting better and the patient is not clinically anemic. So I would continue with the same management. But I agree with you, it's kind of tricky ones. Yes. One last question is a 46-year-old woman is usual follow-up clinic with a background history of hypertension, type 2 diabetes, doing very well since her last visit, participating in an exercise program where she walks about 30 minutes 4 times weekly. She states that since she has started exercising, her finger stick blood glucose has improved and the range is 90 to 160. Only medication is aspirin 81 milligrams. A physical examination is okay, and his PMI is only 28. The main question, have a wee look on the bloods and what is the following most appropriate steps in the management of this patient? Shall we add metformin, given her background of type 2 diabetes, or to her mix of blood, mix of medication, kidney biopsy, repeat ECR in 3 months, or measure immune fixation, add losartan? Okay, we started to have some answers, including ACE inhibitors or, yeah, losartan, good. C, repeat ECR in 3 months, Dr. Osama, Dr. Hamid. E is again losartan. So, right, in the chat box, please, given that this is the last question, whoever choose C or E, would you mind putting just one sentence about your support, why you choose that? Blood pressure is normal. Okay. She had a microalbuminuria. Rest control blood sugar, then target treating proteinuria. Excellent. HA hemoglobin 1C is high. Yeah, it's above the target, yes. Perfect. So the answer is C. And the reason for that is the American Diabetes Association recommends screening as usual for albuminuria, ACR, and type 2 diabetics. However, when it exceeds 30 milligram, it's recommended to repeat the testing within 3 to 6 months. Right. When you should action, when you have a documented 2 or 3 elevated ECR collected over 3 to 6 months is required before considering the patient having increased urinary albumin creatinine ratio. And at that point, yes, you need to action it by adding some ACE inhibitors. Thank you.
Thank you very much. Hopefully you enjoyed my lecture.
And that was Professor Halawas. Thank you very much for joining us today. It has been a pleasure over the last 2 hours nearly to have you all I put in the chat box more information about the course. If you'd like to register or join the WhatsApp group, it's free. Please feel free to join. It has been a pleasure. Professor Halawa, would you like to add anything?
No, thank you very much. Actually, again, in order to pass the exam, you have two principles basically to pass the exam: knowledge and to understand and appreciate the practice, the MCQ. To practice the MCQ is important. To practice the exam question is important. Without knowledge, you cannot pass. Without good practice and understanding and the tricks and cracking the MCQ, you wouldn't pass. You would do a lot of mistakes. And this is why the course is for. It's just combination of knowledge and practice. Thank you.
Thank you. Thank you, Prof. Halawa. Dr. Rami, would you like to add anything?
Nothing. Thanks, Dr. Ahmed. It's, as we all mentioned, this is amazing gathering of all the MCQs we have. For the past 8 months, we are collecting MCQs from everywhere, just to make a huge and very advanced bank for every nephrologist he want to pass. So whatever exam he will go for, either nephrology fellowship, Egyptian fellowship, or other fellowship. So it will help you a lot in revising your information and to go directly to the right answer in your exam. And I wish all of you the best of luck.
Thank you again, Dr. Rami. Yes, the course is full of videos and explanations, top tips, MCQs. Feel free to join. Feel free to send me messages through the WhatsApp or the WKA Academy email. Happy to answer. Thank you very much for joining us for this fruitful event today, and all the best. Thank you.
Thank
Bye.
you.